And we are now live. Today's webinar presentation will begin in 3 minutes. Today's webinar presentation will begin in 1 minute. Welcome to today's webinar, HCV Post-Cure Monitoring and Management. I would like to introduce Dr. Marion G. Peters, MD, Professor Emeritus of Medicine at the University of California, San Francisco. Welcome, Dr. Peters.
Thank you very much, and welcome to everybody. Just a few housekeeping things. If you want to update your account, you go to IAS-USA is here and log on. And if you've not previously logged on to the new website, you'll need to use your email address and reset your password. CME information is accredited for physicians for 1.25 hours, and you can only claim the credit depending how long you are in this activity. There's also nursing credits and pharmacy credits, and these will be posted for you to see. Evaluations will be available in your My Activities page by 5 p.m. Pacific time today. So you need to go to the IAS-USA website for instructions on how to claim your CME for pharmacy, nursing, or pharmacotherapy credits, or a certificate of participation. If you don't receive IAS-USA emails, check the frequently asked questions section for more information. We're very pleased that we have a number of industry sponsors for this webinar, as noted here, because we wouldn't be able to do it without their support. When we navigate the webinar, when there's a poll question, don't write in the chat box, but actually choose your response from the poll, which will look like this here, and go directly to this picture on your screen and choose your response. And then at the end, the responses will be displayed after the poll closes. If you want to ask a question, you should type in the chat box, and questions will be answered perhaps during the session or at the end of the webinar. We're sort of piloting to see whether it would be helpful to answer questions during the webinar. All the questions I've received so far are really questions for the latter part of the talk, so I won't be discussing them till the end. So let's get you poll organized. From what geographic region are you viewing this webinar? And you get choices in the US, Canada, Mexico, South America, Europe, Australia, Africa, or other. So only some of the people are voting, but that's all right. So most people are here from the U.S. and represented throughout the U.S. Okay, you can close this. The next is please rate your level of experience. Whoops, this is wrong. This question is not correct. Please rate your level of experience in the medical management of HIV from novice to expert. And we'll see if we can pull this one up. Any luck getting this one up? Michelle? Here it is. Okay. Okay, so most people have significant amount of expertise, but there are some novices. Next question, we close this poll. So now I'm going to, well, these are my financial relationships, honorary from Antios, Alagos, and Abbott, and my spouse is employed by Hoffman LaRoche. At the end of this webinar, you should be able to assess the common liver-related problems seen in patients who have had hepatitis C, describe the regression of fibrosis after SVR or cure, delineate potential liver-related health problems after cure of hepatitis C, and describe aspects of liver disease that require follow-up and management after cure. So we have some pre-test questions. The first one is, which statement about the impact of curing hepatitis C is correct? No overall change in mortality, higher risk of liver decompensation, elimination of the risk of hepatocellular carcinoma, worsening of cirrhosis or fibrosis, and reduced risk of transmission to others. So which of these questions is correct? Okay, so the next question, we'll close that, is which statement is true? Non-invasive tests to stage liver fibrosis are reliable measures to stage fibrosis after cure. Following cure, liver biopsy should be used to assess fibrosis progression. Management of patients post-cure should be based on pre-treatment fibrosis staging. And elastography evaluation post-cure is more useful to assess progression than regression. And I think we have one more. Which statement is true? Patients with cirrhosis prior to treatment do not need HCC monitoring post-cure. Comorbidities such as fatty liver, diabetes, and older age place patients at risk, increased risk of cancer. Following cure of hepatitis C, all alcohol consumption is safe, and all patients should have ongoing monitoring for reinfection following cure. Okay, so now we'll get started on the talk and come back to these questions at the end. There are many
We apologize to the audience. It appears that we have lost connection of Dr. Peters. We will try to reconnect her into this presentation. Again, we apologize for this.
Thank you, everyone, for your patience. We are getting Dr. Peters back on the line shortly.
Okay, I really apologize for that. I don't know what happened, but I got cut off, I think, at this slide. If you can't hear me, please send me a text, please, Michelle. So this is a slide showing that HCV treatment dramatically decreases HCV-related morbidity and mortality. So on the left is all-cause mortality, markedly decreased from the patients who didn't have an SVR to those who did. So cure decreased all-cause mortality, decreased liver-related mortality or need for liver transplant, decreased the incidence of HCC but did not obliterate it, and markedly decrease the occurrence of liver failure. And factors that were associated with the worst outcome were older age, genotype 3, worse fibrosis to begin with, diabetes, or severe alcohol. And this is a follow-up slide from Vandermeer, where he took 192 patients with SVR and 405 with non-SVR. So these were patients taken from 5 large hepatology units in Europe and Canada. Then he age, sex, and calendar year matched controls from the Netherlands. So on the left you see patients with SVR compared to these matched controls, and they have the same mortality. On the right are patients who did not have a cure, and you can see markedly decreased mortality with the significant p-value. So cure improves mortality, improves liver-related mortality, improves the risk, decreases the risk of HCC and of liver failure. Here's a slide that you've probably seen before, a large meta-analysis of 129 studies of over 34,000 patients. And on the left is the 5-year risk of death. And SVR is in green because that's good, and non-SVR is red because it's bad. And you can see overall that all-cause mortality decreased by half, even in cirrhosis, even more so by a third, and in co-infected patients by over 80%. And on the right is the risk of HCC, overall markedly decreased, decreased by nearly 2/3 in cirrhotics, and in co-infected decreased by over 90%. So great data. This led to a decrease in the need for liver transplant. So if you look on the left, red is hepatitis C, blue is fatty liver, and you can see it's increasing markedly, and it's going to take over as the most common cause for liver transplant very soon. And green is hepatitis B. So looking at hepatitis C in red, it was increasing over the interferon era, stabilized with the protease inhibitors and is now decreasing. If we look at the need for liver transplant because of decompensated cirrhosis, you can see this has taken a marked dive over the last few years. Although the need for transplant for hepatocellular carcinoma is not dropping as much because patients are still having hepatocellular carcinoma. So what about extrahepatic manifestations? First question, which statement is true? Extrahepatic manifestations do not reverse after SVR. SVR improves renal disease in diabetic patients. SVR reduces the incidence of diabetes. SVR is not associated with improvement in lymphoma or B and C. Okay, and the next question is, here are the extrahepatic manifestations, which you can see are protein. There are hematologic manifestations with mixed cryoglobulinemia, non-Hodgkin's lymphoma, aplastic anemia, thrombocytopenia, dermatologic, PCT, lichen planus, vasculitis, renal, glomerulonephritis and nephrotic syndrome, endocrine, hypothyroidism and diabetes. There are ocular manifestations, corneal ulcer, uveitis, cardiovascular, including stroke, acute coronary syndrome, polyarteritis nodosa, neuromuscular, including weakness, myalgia, peripheral neuropathy, arthritis, arthralgia. Even CREST can occur, and there are, as you know, psychiatric manifestations with depression and fatigue. So, benefits of cure on extrahepatic disease. This is a large study looking at 10,000 patients who were cured and 20,000 who were not. And you can see that cure decreased the risk of mixed cryoglobulinemia. The cure reduces the mixed cryoglobulinemia by 45%, glomerulonephritis by nearly 30%, PCT by 60%, diabetes by nearly 30%, non-Hodgkin's lymphoma was not significantly decreased in incidence, but in response, and I'll show you those data, and decreased lichen planus. So it didn't obliterate all extrahepatic manifestations, but markedly decreased them. So this is a slide looking at the prevention of insulin resistance. So if you look on the left, this is a baseline of 384 patients who did not have insulin resistance, and 29% of them were cirrhotic, and they had HOMA-IR to assess insulin resistance before hepatitis C treatment and then after. So these are not patients with diabetes, and you can see the de novo development of insulin resistance was much higher in the red non-SVR patients than in the blue SVR patients, and that was true for all genotypes. It was higher in patients who didn't have a cure and higher in patients who had higher BMI. On the right, and these are all interferon treatment studies. On the right is a different study looking at 2,800 patients followed for over 6 years to look at the development of type 2 diabetes. And this is the development in patients who were not cured, nearly 30%, compared to less than 10% in patients who were cured. And they found diabetes incidence was higher if you didn't have an SVR, if you had severe fibrosis before treatment, and in older age. So cure prevents the development or decreases the development of insulin resistance and diabetes. Here's a different slide looking at patients with diabetes.
We apologize again for the technical issue that we are experiencing. Dr. Peters should be joining the line shortly.
All right, I think I'm back now. I've changed my phone. So send me a text if you can hear me. I can hear you, thank God. I really apologize. I don't know what the problem is. Must be something bad about San Francisco. So this is a slide looking at patients who have diabetes. So they either had diabetes with hepatitis C or diabetes without hepatitis C. And on the left is the incidence of end-stage renal disease in non-hepatitis C patients with diabetes compared to hepatitis C patients who were treated or not treated. And you can see if they were not treated, they had the highest incidence of end-stage liver disease compared to those who didn't have hep C. But if they were treated for hep C, their incidence of end-stage liver disease was less than that as if they didn't have hep C. Now, these studies, there are over 8,000 patients. They didn't do HCV RNA. They don't have cure data. On the right is the incidence of ischemic stroke. And you can see that if you treat with hepatitis C down the bottom, that's better than not having hep C or no treatment. And when they looked at hazards ratios, that they decreased end-stage renal disease by 84%, ischemic stroke by nearly half, and acute coronary syndrome by a third. So not only did it prevent the development of hepatitis C, of diabetes, but if you have diabetes, it markedly decreased the complications of diabetes. What about cryoglobulinemia? This is 18 symptomatic and 65 asymptomatic patients, of whom 10 of the symptomatic had severe or life-threatening vasculitis. 61% were male, 58% female. 79% of the patients received interferon-based therapy and the other 20% DAAs. They had an SVR in nearly 90% of both symptomatic and asymptomatic. And they found that cryoglobulins disappeared in a third of the symptomatic and half of the asymptomatic. And I'll show you some data on that in a minute. In the symptomatic patients, they had a complete clinical response to the cryoglobulinemia in 38%, a partial response, that is a 50% reduction in cryocrit, in another 4. Of the patients with severe vasculitis, 6 achieved cure of hepatitis C, and in those, 1 had a complete response to cryoglobulinemia, 3 had a partial, and 2 had none. All 4 of the patients with life-threatening vasculitis required plasmapheresis, and 3 received rituximab in addition to HCV cure. And all of those who achieved a cure, none had a complete response, 2 had a partial, and 2 had no response. So some improvement, but not 100%. What about skin manifestations? They found a 39% reduction in skin manifestations, 11% reduction in renal disease. In fact, 2 patients stopped hemodialysis, 11% reduction in neurologic symptoms, and all but 1 patient completed therapy. 22% reported adverse events, and 5 of those of the 19 had adverse events hospitalized for liver decompensation, and 4 of them for worsening vasculitis. So not just the liver disease, but also their cryoglobulinemia caused problems. This slide shows you the cryocrit, and you can see 2 things. First of all, this is
Dr. Peters, I apologize for interrupting. Your audio is getting a little bit scratchy.
Well, when I do it on my cell phone, it keeps hanging up on me. What will I do?
This is better. This is better.
It's better not to hang up, right?
Correct, correct. Why don't you keep going, and then we'll let you know if it's still scratchy.
Let's see if I can go. I think I'm going to have to stick with this. I apologize to everybody. Can you still hear me?
Yes, we can, and that seems to be better. Thank you.
Okay. So this dotted line is the asymptomatic. And you see 2 things. First of all, it's a lower cryocrit. So patients who are symptomatic most often have a higher cryocrit. And secondly, you can see that because it starts off lower, it becomes undetectable post-treatment for hepatitis C, as opposed to those with symptomatic cryoglobulinemia, where it starts higher and comes down equally fast, but not to 0. What about lymphoma? This is 61 patients receiving PEG interferon, 10 DAAs. 38% had diffuse large cell lymphoma, 31% marginal zone. And they found that the response to non-Hodgkin's lymphoma treatment was 69% in those who were cured of their hepatitis C, but only 31% in those who weren't cured. So cure of hepatitis C improves the response to non-Hodgkin's lymphoma. In these patients, 30 had a complete and 12 a partial response. And using DAAs, the vast majority of patients had SVRs, so obviously much easier to treat patients with DAAs, as everybody knows. And this is a large meta-analysis of 254 patients with non-Hodgkin's lymphoma and hepatitis C. The overall lymphoma response rate was 74% after cure of hepatitis C. It was 83% in those with SVR and 53% in those without. They found a better response after cure in HCV-associated marginal zone lymphoma compared to non-marginal zone, and conclude Peveling's study that antiviral therapy is really the first-line treatment in patients who do not immediately need conventional therapy. And the strong correlation between cure of hepatitis C and lymphoma regression supports the causal relationship of HCV and lymphoma development. So what about physical and mental benefits? We all know that patients with hepatitis C have a lot of psychiatric, neurologic abnormalities. And this is a study of SOFT-VEL, where they actually looked at physical and mental well-being, whether they were on placebo or SOFT-VEL. So if you look at the end of treatment is the dotted line here, and you can see that the physical improvement started to occur even during treatment and continued afterwards, and the mental improvement in dark blue the same compared to the pale line or the black line where there was no improvement on placebo. So DAAs and cure of hepatitis C leads to improved physical and mental benefits. So I don't have any questions at this point, so I'm going to keep going and take questions at the end. What about co-infected patients? The thing is that co-infected patients are no different anymore than mono-infected. And this is a slide from the Gasita cohort in Spain, where you can see all-cause mortality markedly improved with cure compared to non-cure, and liver-related death markedly improved, exactly the same as I showed you earlier for mono-infected. But they also looked at non-liver issues. So 1,500 patients, of whom 39% had an SVR, and they followed them for 5 years. And if they weren't cured, they had a higher rate of AIDS-defining conditions, a higher rate of non-liver-related deaths, and a higher rate of non-liver-related, non-HIV-related deaths. And the hazard ratios you can see are very significant. So not only in co-infected patients do you get improvement in all-cause mortality, in liver-related mortality, but also in AIDS-defining illnesses. And they also showed in another paper, because they're very good at writing papers, that they decrease the risk of diabetes mellitus and chronic renal failure. Just the same as the data that I showed you in mono-infected patients. Now a question about reinfection. It's very important to tell your patients that HCV antibody is not protected and reinfection can occur. This is recent data from over the last year from the GECKO cohort in Germany, where the risk of reinfection in MSM was 9 per 100 patient years, compared to 1 in patients with IV drug use. And in Madrid, high rate of reinfection in MSM, 5.9. And in Canada, they only looked at their PWIDs, patients with injection drug use, and it was 3 per 100. So you have to know how, or try and find out how your patient got infected, and if they're MSM or PWIDs, they have to be cautioned about the risk of getting reinfected. So on the left here, this is looking at French data where the incidence of HCV is still increasing in HIV-infected MSM. You can see it going up compared to all, which is going up a little bit. It's going up markedly in MSM. On the right is the amazing data from the Dutch cohort that was published in the last 18 months, showing the declining incidence of acute hepatitis C and MSM because the Dutch government gave unrestricted access to hepatitis C therapy. And associated with that, it was treatment as prevention, both genotypes 1 and 4. On the left here is the outcome after acute hep C. This is the German NEAT study, so it's a pan-European study, looking in co-infected patients how frequently they spontaneously clear acute hepatitis C. And you can see on the left, spontaneous clearance was 11.9% compared to the vast majority of patients who had persistent viremia. This led to a study from Boston, a decision and cost effectiveness analysis on the right, trying to assess whether treatment as prevention, as I showed you in the Dutch study, is cost effective. And you can see from this study, if spontaneous clearance is low, and in the co-infected it's down here, and the SVR rate is high, it's highly cost-saving. So cost-effective is less than $50,000 per QALY. Well, you can see here it's way lower than that, and in the co-infected patients it's down here. So treatment as prevention is cost-effective. No questions yet. So now we're going to get to the most difficult part of the talk, and it's where all the questions came from you. And we will hopefully go over these because we don't have answers at the moment about how to assess regression of fibrosis after SVR. But I'll talk to you about the data we have, plus potential liver-related health problems after cure, and what aspects of liver disease require follow-up and management. So this is a very nice study from quite a long time ago with interferon-based therapy, looking at paired liver biopsies before and after cure. The biopsies were done from 4 years to 8 years post-cure. And this is looking at the area of fibrosis here on the y-axis, and on the x-axis is before treatment and post-treatment on the left-hand slide. And you can see that almost every patient decreased the amount of fibrosis they had. 89% had decrease in the area of fibrosis, and only 8% had increase. And on the right, they looked at on the y-axis, the area of fibrosis, and on the x-axis, after treatment, and on the right-hand side in the dark box, before treatment. So you can see this was the spread of Child-Pugh A cirrhotic patients, quite a significant amount of fibrosis, and after cure, they all went down, and some of them even to F1 or F2. But even the cirrhotics here, F4, had decrease in the area of fibrosis. So this was very, very exciting, showing that in the majority of patients, you do get improvement in fibrosis. But you still have a lot of patients who have remain with cirrhosis. Whoops, next slide. So then this slide looks at how good liver stiffness is in assessing fibrosis after cure. So these are paired liver biopsies and liver stiffness measurements. So they did liver stiffness and biopsy. For this, they used acoustic radiation force impulse, ARFI, elastography. They had 121 patients with cure who were in the clear boxes compared to 215 with chronic Hep C. So if you look at the slides on the left, here is the fibrosis stage in the x-axis and the liver stiffness in the y-axis. In each case, the liver stiffness value was lower for fibrosis stage in patients who were cured. So that's the first thing. It agrees with the slide I just showed you that cure leads to decrease in the amount of fibrosis. Also, the higher the ALT, the higher the ARFI, and the longer time from cure, the lower the amount of liver stiffness. But it doesn't, for each fibrosis stage, biopsy, there is still stage 3 and 4, suggesting we need new cutoffs to define the stage with cure. And this is the latest data that came out a few months ago, where they took patients who'd been cured of hepatitis C and were having resection for hepatocellular carcinoma. So that means they were Child-Pugh A, they didn't have portal hypertension, and they were anywhere from 4 to 40 months post-cure. They were all compensated, and they looked at their ALT before cure on the left, their FIB-4 score, a serum marker of fibrosis, and their liver stiffness elastography. Then after cure, the same 3 plus a liver biopsy. And you can see, first of all, ALT has decreased markedly in all 10 patients. Secondly, FIB-4 has decreased in the majority of patients because FIB-4 relies on AST and ALT, and if that decreases, it decreases how much fibrosis that predicts. In addition, liver stiffness, if you look at patient 1, went from 29 to 14, but the patient still had cirrhosis on biopsy. Liver stiffness greater than 12.5 is cirrhosis. But patient 2 had cirrhosis, even liver stiffness said F2. Patient 3 had cirrhosis, even though liver stiffness said F1. So biopsy proven was much worse stage of liver disease than what liver stiffness would predict, telling us, unfortunately, that liver stiffness is not a way to predict regression of cirrhosis because the ALT goes down so much and that affects the liver stiffness. We all know you shouldn't do elastography on patients whose ALT is over 100. But it's also probably true that if their ALT goes from 89 to 16, that markedly decreases the risk, the markedly decreases the level of liver stiffness. So this is a conundrum we have not solved. What about, so non-invasive tests have not been validated post-SVR, and there's a big risk of underestimating the severity of fibrosis by relying on APRI or FIB-4 or liver stiffness. So pending more studies, we have to manage patients on their pre-treatment fibrosis stage. Elastography post-SVR is more useful to assess progression, so if it gets worse rather than regression, because regression may be falsely affected by ALT. So what do? You have to assess the pre-treatment fibrosis stage, because that not only for post-treatment management, but also if they have cirrhotic, do they need different therapies? You really need to know what their fibrosis stage is. If it's low, they don't need to be further monitored. They can go back to their PCP. If it's advanced, F3, F4, they need long-term follow-up and surveillance for HCC and varices. And if they're in the middle, they need to monitor for progression of liver disease. What about variceal surveillance? All patients with pretreatment cirrhosis should have a screening endoscopy, and you can't use the guidelines of elastography less than 20 and platelets greater than 150 to identify patients at low risk. You just have to screen everyone. If they're negative, we actually don't know what to do. Most experts recommend repeating your EGD at least once. If there are varices at baseline, their patient must be followed up with another EGD. And of course, if a patient has portal hypertension, they need to be monitored for cancer and for varices. And this is portal hypertension radiologically or clinically. So what about HCC post-cure? This is the risk of hepatocellular carcinoma and liver complications or decompensation in patients with advanced fibrosis. And you can see the risk of cancer is 10% at 10 years and 23% at 20 years after cure. And on the right, even decompensation can occur with time, probably related to comorbid conditions. So you can't just ignore a patient if they're cirrhotic. A quick word on the incidence of HCC post-cure. The natural history incidence is 3 to 7% a year. Interferon-based therapy is less than 1.5% per year. But remember, we didn't like to give interferon to patients with cirrhosis. Whereas DAAs, we gave them to everyone, and it's 3 to 5% a year. When you look at the bigger data, it's round about 1 to 4% per year. And the higher incidence seen with DAAs reflects the treatment of older patients with more advanced cirrhosis and more decompensated disease. And when El-Siraj looked at 33,000 VA patients, of whom 10,000 had a cure, he had 100 new cases in the SVR patients and showed that this is in interferon-based therapy, that the risk is 0.33% per year compared to 1.3% in those who are not cured. And the patients who are at most risk of cancer are the patients who had SVR, had cirrhosis at the time of cure, older patients, patients having heavy alcohol, Hispanic patients, and those with diabetes. So those with comorbid conditions and those with worse liver disease. The predictors of cancer after a cure in many studies that are highlighted at the bottom here are older age patients, genotype 3 patients, patients with worse liver disease, patients with portal hypertension and decompensated disease like lower platelet count, low albumin, patients with comorbid conditions like diabetes, insulin resistance, and alcohol use, or patients with elevated AFP at the end of therapy. What about concomitant liver disease? This is a very nice study from Susanna Nagy and Mark Sulkowski, looking at 275 patients who are mono and co-infected, and nearly all of them had liver biopsy prior to treatment. After cure, 12% of them still had abnormal ALT, and of those with HIV, 20% had an abnormal ALT. And the risk factors for a higher ALT were HIV, steatosis, antiretroviral toxicity, alcohol use, statins, reflecting metabolic syndrome, or severe fibrosis cirrhosis. So there are many HIV-related issues that can cause concomitant liver disease. There are hepatitis C-related, insulin resistance, and the pro-inflammatory state. And there are host-related, alcohol, older age, metabolic syndrome, and medications and co-infection. So the liver-related health problems after cure, the things that you have to think about before you release the patient back to their PCP, or think about as you're ongoing, you are the PCP monitoring these patients ongoing. You have to prevent fatty liver disease and the metabolic syndrome. Obesity is seen in a huge percentage of the U.S. population. We need to optimize weight, prevent and treat diabetes, treat dyslipidemia. There's some data that coffee drinking is associated with a lower risk of progression, which is great since we all abuse it. Daily cannabis is not a good idea. There are no safe levels of alcohol if a patient has advanced fibrosis. If a patient has no fibrosis prior to cure, they can take normal NIAAA recommendations for alcohol use, 7 drinks a week for less than 4 to 7 drinks a week for women and 7 to 14 for men. Patients should be cautioned to the use of herbs and spices because many supplements and herbal remedies have a potential for hepatotoxicity. What are the other benefits of cure? Their lower rate of extrahepatic complications, decreased cryoglobulinemia, reduced diabetes, reduced renal disease, better response to non-Hodgkin's lymphoma, reduced mortality not related to liver disease, reduced HIV progression, improved quality of life and work productivity. So telling us that what we already knew, that hepatitis C is a pro-inflammatory state, that if you can get rid of that pro-inflammatory state, you don't just improve the liver, you improve the whole body. So in summary, there are many benefits of HCV cure that are both liver and non-liver. Those with F3, F4 pre-SVR need HCV monitoring post-cure. You need to stage fibrosis pre-treatment to optimally monitor how to follow them post-cure. Concurrent alcohol or fatty liver places patients at risk for future cirrhosis, so they need to be monitored for fibrosis progression. Counseling healthy liver practices is critical for all patients, and patients should be monitored for reinfection, those who are at risk, MSM and PWIDs. So which statement about impact of curing hepatitis C is correct? There's no change in overall mortality. There's a higher risk of liver decompensation. There's elimination of the risk of hepatocellular carcinoma, worsening of fibrosis, or reduced risk of transmission to others. Okay, so pretty much everybody said that it's a reduced risk of transmission of infection to others, and that's been very clearly shown. It decreases the risk of cancer but doesn't eliminate it. It decreases the worsening of fibrosis, cirrhosis, but doesn't eliminate it. So the next is which statement is true. Non-invasive tests to stage liver fibrosis are reliable measures to stage fibrosis after cure. Following cure, liver biopsy should be used. Management of patients post-cure should be based on pre-treatment fibrosis staging, and elastography evaluation is more useful to assess progression than regression. So non-invasives, unfortunately, measures are not reliable because they rely on AST/ALT. And management should be based on pre-treatment staging. And true, elastography post-cure is more useful in assessing progression than regression. Next slide. Which statement is true? Patients with cirrhosis prior to Hep C treatment do not need monitoring post-cure. Comorbid conditions such as fatty liver, diabetes, older age place patients at risk for cancer. Following cure, all alcohol consumption is safe, and all patients should have ongoing monitoring for reinfection following cure. So comorbid conditions, place patients at greater risk. That is absolutely true. So if a patient has metabolic syndrome, diabetes in their older age, I would be monitoring them much more carefully. And we don't know what alcohol consumption is safe. We know if they have F3, F4, no alcohol. In patients who are at risk for reinfection should have ongoing monitoring. So let's get to the questions. Do you recommend HCC screening for patients with pre-treatment F3? Because the guidelines have gotten rid of it. EASL did not get rid of it, but AASLD did. And the reason they did is a question of risk-benefit analysis. What's the benefit of monitoring F3? So I think I would go with a couple of statements. First of all, look at if you have an assessment with a liver biopsy pre-treatment, make sure you know that it's an adequate biopsy, because the smaller the piece, the lower the fibrosis stage. If you have transient elastography and it says 15, which is well and truly cirrhosis, I would be following that. If it's 11, then you could say, well, I won't monitor the patient. Maybe I'll do one screen afterwards, and if everything looks good, follow the patient without ultrasound. Somebody said, if you follow the patients, why do you do alpha-fetoprotein? We do alpha-fetoprotein not because it's beneficial on its own, but it does add, in a patient who has an elevated alpha-fetoprotein, it can be used to monitor progression and regression of disease. If a patient has a alpha-fetoprotein that's 250 and you don't see anything on ultrasound, I would move to a CT at that point. When would you consider a PI-based DAA in patients? And you should avoid protease inhibitors in patients who have decompensated liver disease, and I would recommend you go to the HCV guidelines, IDSA, AASLD, because they really very clearly delineate, if you put in what your patient has, what the patient should be treated with. In the era of PrEP, the challenge of reinfection of Hep C is frequent for MSN. How do you address this issue other than developing a vaccine? Well, it's recommended that patients have HCV RNA every 12 months if they're at high risk for reinfection for hepatitis C. And unfortunately, you know, the vaccine study failed, so we don't have a vaccine soon on the horizon. And treatment as prevention, if patients aren't monogamous, then they're at higher risk, and treating the the group of patients who have hepatitis C may decrease infectivity. How do you get around not monitoring Hep 3? It's severe fibrosis but not cirrhosis, as I said. If the patient has F3 and not F4, the guidelines in the US do not recommend monitoring. In Europe, they do. Can you comment on the underlying reason why elevated ALT and liver stiffness are correlated? So it's related to the fact that if you have inflammation in the liver, after all, what the transient elastography does is look at how stiff the liver is. If the liver is full of inflammatory cells, it will be stiffer than a liver with no inflammatory cells. So when we looked at patients post-transplant who had acute cellular rejection, their liver stiffness was extremely high, even when their ALT wasn't. So I think it's related to the fact that if you have that, not just fibrosis increases liver stiffness, but cellular infiltrate does, eating. So if the patient has eaten within 3 hours of the FibroScan, it will falsely elevate the liver stiffness because of increased portal vein flow. So that's why elastography is inferior to liver biopsy. Is it worth rebiopsying patients? Well, that's, biopsy is an invasive issue, and when we think about, do we want to stop, if a patient has portal hypertension, that's pretty easy. You're never going to stop screening them and ultrasounding them for HCC and EGD. But if they don't have portal hypertension and they desperately want to stop treatment, it is a possibility. But I think we have to come up with a better way of monitoring patients post-transplant, post-cure, to see have they decreased from cirrhosis to lower stages of fibrosis. Can you speak to the place NS5A resistance testing? Hang on, I'm not seeing that answer properly. That presents the same genotype. Well, I don't think NS5A resistance testing is going to differentiate between reinfection and true treatment. If it's a different genotype, of course, that's easy. If it's the same genotype, subtyping is the way to go. But in practice, we just retreat the patient. How do we monitor F3 patients for whom the only fibrosis testing available is a blood test? If you only have a blood test available, you can only use it, but you have to know when the ALT go down, it is going to affect your fibrosis testing. And an MRI doesn't diagnose fibrosis, so you can't make your screening decisions on that. Do we anticipate we will develop a stratification algorithm to identify patients with pre-treatment F4 who would not require lifelong HCC screening? Everybody wants to know the answer to that, and I am sure, since so many people are working on it, that we are going to get an algorithm in the next 3 to 5 years. But we don't have one yet, and it's very, very frustrating. If you suspect a relapse with IV drugs, you should repeat HCV RNA. Yes, it's the only way to determine if the patient is reinfected. Is there an alternative for RNA? Somebody asked about HCV antigen. What I will tell you is the antigen has a much higher lower limit of detection, around 500 to 1,000, compared to less than 20 or less than 10. So if that's what's available to you, you can use it, but it may take further time for it to be elevated. Someone asked the billing and chart diagnosis for patients who are cured from hepatitis C. Michelle, could you type this in the chat box for everyone? Because I can't, I only have 2 hands, and one of them's holding a telephone. It's history of hepatitis C, and the ICD-10 is Z86.19. And that's the diagnostic. Remember, a Z code needs something else on top of it. So you have to also either do fatty liver, diabetes, metabolic syndrome, screening for acute disease. You need to be doing something else. I guess Michelle isn't typing it, so I'm going to do it. Z86.19. There you go. Patients treated with a DAA who have recurrent viremia without a genotype switch but with a transmission risk factor, would you consider this a reinfection or retreat? Now that is a challenge, especially if it's early. If it's in the first, if it's within a few weeks post end of treatment, it is most likely a relapse. And once again, depending on the genotype and what treatment you used, the guidelines will easily tell you what to do next. the genotyping, the people you're worrying about are people with genotype 3 with cirrhosis, or certain therapies where you can't use it without testing. So what I would recommend is repeating the HCV RNA. If it's positive and it's the same genotype and you have the patient on, for instance, Sofvelvox, then I wouldn't be, and they didn't have that treatment to start off with, I wouldn't do RAS testing at that time. F2 patients, what test do you recommend as ongoing liver progression? Well, we know that that patient is most likely to have regression of disease and is not at risk of HCC or cirrhosis, so I would monitor that patient with just regular liver tests. Next question is, the most fibrosis scores, to my understanding, do well differentiating between cirrhosis and no cirrhosis, but not between the intermediate stages. Elastography is similar. We don't always have access, or patients don't follow up with elastography referrals. The issue is that you've got to know what they are before treatment. If they're cirrhotic before treatment, you need to monitor after treatment, whether you use FIB4, elastography, or biopsy. Is it ideal? No. Is it perfect? No. Do we have a better answer? Unfortunately, no. But it doesn't, if they're not cirrhotic pre-transplant, they don't need to be monitored post-transplant, unless they have fatty liver disease, where they need to be monitored for progression of fatty liver disease, and you can do that with elastography and CAP. Does psychedelic psychotherapy have an impact on outcomes? Not as far as I know from any data. If a patient has a confirmed SVR12 on a DAA and subsequently has another infection, would you treat as naive, or would you recommend treating with Vocivi? What I would say is, in that patient, I would do genotype to see if they have the same genotype. If they have a different genotype, I would treat them as a reinfection. If they're a long time out from their SVR and they have a risk factor, I would treat them as a reinfection. Do you endorse the use of FIB4 or Fibrosure pre-treatment to determine post-treatment need for HCC screening? If that's all you have, it is 80% correct. So you will miss 20% of people who might need post-treatment screening, but if that's all you have, that's all you can use. If you have another infection with the same genotype, do you just retreat with the same? Most people who are treating MSM and PWIDs will come back with the same therapy, but if it's in that very early stage post-treatment, then you might use more potent therapy. Let me see. I think I've come to the end of all my questions. How do you sort out the effects of HCV and NASH? I think that's a very important question. If you've cured the patient of HCV and the patient has metabolic syndrome, then you have to manage the patient as fatty liver disease. If, however, you haven't cured the patient and they don't, you should, one, treat them. If they're non-responders and you can't cure them, that's going to be a very minor number. Then you have to treat them as they have both diseases. And the problem with fatty liver disease is we don't have a cure at this time. And I think I talked about serum plasma antigen as a substitute for HCV RNA quantitation, which can be used around the world. It's not ideal because it has a much higher lower limit of quantitation, around 500 to 1,000, depending which one you use. But if that's what you have, that's what you should use. And I have another question about recurrent viremia at the post-12 SVR without a genotype switch but with a transmission risk factor. That's not always considered automatically a reinfection if it's within the 12-week period. So if it was further out, you would treat it as reinfection. If it's earlier, you would then treat it as a failure, and depending on what drug you first use, do RAS testing and retreat. I think now we have come to the end of our question and answer session. I really apologize for the problem with my phone. I don't know, we had some little genie and